Hello and welcome to this video. In this video, we're going to be discussing on fetal circulation. Let's get started. Fetal circulation refers to the flow of blood within a fetus while in the womb. The placenta plays a crucial role in this process by providing oxygen and nutrients to the fetus and removing carbon dioxide and waste products. In utero, the fetal lungs and the GIT system do not function because the fetus obtains oxygen and nutrients necessary for its development, growth, and well-being from the maternal circulation. The waste products of metabolism pass back into the maternal circulatory system for elimination through the placenta. The oxygenated blood from maternal circulation is passed through placenta to fetus through the umbilical vein, and deoxygenated blood is returned to maternal circulation through umbilical arteries. As a result of these differences, certain modifications are found in the fetal blood circulation which take the form of temporal structures. These structures do not function when the baby is born. In normal circumstances, good maternal respiration depends on normal circulatory changes at birth. Adequate tissue oxygenation is assisted by a rapid fetal heart rate and increased oxygen carrying capacity, which is higher than adults. Additional structures are present in intrauterine circulation. The birth process imposes a significant and unique physical challenge to the neonate. The transition from a fetus to a newborn is a complex adaptation. Let's review the adult circulation before we move on with fetal circulation. So the venous blood from the upper extremities is returned to the right atrium by the superior vena cava. Venous blood from the lower limbs is returned to the right atrium of the heart by the inferior vena cava. From right atrium, blood passes through the tricuspid valve to the right ventricle, then to the lungs for replenishment of oxygen by the pulmonary artery. The pulmonary veins take newly oxygenated blood from the lungs to the left atrium of the heart, where it passes through the bicuspid valve into the left ventricle. From the left ventricle, the aorta sends blood into two streams. The ascending branch supplies head and upper limbs, and the descending branch supplies all parts of the body below the level of the diaphragm. Following its circulation to upper and lower extremities, the blood is again returned to the heart by the superior and inferior vena cava. During intrauterine life, lungs of the fetus are inactivated and interchange of oxygen and carbon dioxide takes place through the placenta. Extra structures are present in the fetal circulatory system which become useless once the extrauterine function of respiration is established. Before the baby is born, there are a lot of adaptations that allows it to survive in utero, such as to take nutrients, oxygen, and eliminate waste. These adaptations include placenta, umbilical vein, ductus venosus, foramen ovale, ductus arteriosus, umbilical artery. Let's start by discussing the placenta. The placenta has two surfaces. the maternal and the fetal surface. The maternal surface is called the chorion and the fetal surface the amnion. Fetal capillaries are deep into the placenta such that oxygen coming with the maternal blood diffuses through to the fetal blood. This process begins at week 6 and is completed by week 12. Okay, so we have the placenta here. Okay, so this is the entire placenta. Okay, now from this placenta we said it has two main surfaces. The fetal surface, which is this one, this is the fetal surface, so it faces the fetus and it is the same part here. Okay, then this other part is what we refer to as the chorion, which faces the mother. Okay, so this is the maternal surface part of the placenta. So we have the fetal part and the maternal part. Let's now discuss the umbilical cord. The umbilical cord has two umbilical arteries and one umbilical vein. The two umbilical arteries, they return non-oxygenated blood and fecal waste to the placenta. Then the umbilical vein brings oxygenated blood and nutrients to the fetus. Let's now discuss the ductus venosus, which is a temporal structure in fetal circulation. So this is simply a duct from vein to another vein. This vessel is a continuation of the umbilical vein and conveys about 85% of oxygenated blood from the placenta to the fetus. It also causes the blood volume and pressure on the right side of the heart to be greater than that on the left side, which causes the small amounts of blood being routed to go in the liver. And then if there's increased blood flow, this leads to large liver in newborns. The ductus venosus then joins the inferior vena cava just at above the level of the umbilicus. As the inferior vena cava ascends from the pelvis and lower limbs, conveying deoxygenated blood to the heart. This causes a mixing of oxygenated blood from the placenta with deoxygenated blood from the lower half of the fetal body. So, from the umbilical vein, blood enters the liver of the fetus and some amount bypasses the liver and enters the inferior vena cava through the ductus venosus. The inferior vena cava drains into the right atrium and 50% of blood from the right atrium enters the left atrium through the foramen ovale. Another 50% enters the right ventricle from there into the pulmonary artery. But fetal lungs are collapsed. So the ductus venosus forms the ligamentum venosus. So the foramen ovale, also known as the oval window. It is an opening in the system between the right and the left atrium of the fetal heart. As the fetal lungs are not functioning, it's unnecessary for the blood to be conveyed to the lungs for oxygenation, and therefore most of the blood from the inferior vena cava passes directly from the right atrium to the left atrium through the foramen ovale. So the valve situated at the entry of the inferior vena cava to the right atrium is so constricted that it directs the blood from the lower limbs through the foramen ovale. The foramen ovale is constructed with a flap on the left side of the septum, and as the pressure is greatest on the right side of the heart. During fetal existence, the pressure of the blood in the right atrium against the valve causes it to remain open, and so allows the blood to flow through into the left atrium. The blood which flows through the foramen ovale into the left atrium is mixed blood, but of high oxygen concentration, which then passes into the left atrium and from there into the ascending aorta. This blood, which is reasonably well oxygenated, is mainly directed to the heart muscle, the head, and the upper parts of the fetal body. So here we have a diagram of the heart. So specifically, this is the foramen ovale that we are talking about. Okay, this is the foramen ovale that we are referring to, that we keep referring to. Okay, which is the oval window. So we also have the ductus arteriosus, which is also known as the aortic isthmus. This simply connects the main pulmonary artery to the aorta. Okay, now let's look at the physiology of fetal circulation. So, like we discussed earlier, the placenta has two surfaces. It has the maternal surface and the fetal surface. The umbilical vein carries oxygenated blood, about 80% of it towards the liver. The umbilical vein has the left and the right branches. The left branch goes to the liver while the right joins the inferior vena cava. The right branch is a shortcut called the ductus venosus, which allows blood to move from the umbilical vein to join the inferior vena cava. The inferior vena cava contains blood from the lower part of the body, which is highly deoxygenated. Blood in the inferior vena cava meets with that from the ductus venosus and is now about 66% oxygenated. This blood enters the right atrium simultaneously with that from the superior vena cava and is now about 62% oxygenated. In the right atrium, blood has two options. First, to go down through the tricuspid valve into the right ventricle, and actually some blood does that. And secondly is to go through the foramen ovale to the left atrium, and a lot of blood does that. From the right ventricle, blood is squeezed into the pulmonary artery, which branches to the left and right lung. In the lungs, there are air spaces that are actually filled with fluids. Passing the air sacs are the arterioles. If they are filled with fluids, then there is not much oxygen. The alveolus helps to constrict the arterioles. The arterioles have smooth muscles, but due to lack of oxygen in the alveolus, the arterioles constrict in a process called hypoxic pulmonary vasoconstriction. This constriction increases the resistance in the arterioles. Increased resistance in the lungs will lead to increased pressure in the pulmonary artery, increased pressure in the right ventricle, and increased pressure in the right atrium. Therefore, a lot of pressure in the right side of the heart. This forces blood to the left atrium through the foramen ovale. So a lot of blood goes into the left atrium than that going down the right ventricle. And little blood is returning to the left atrium through the pulmonary artery. From the left atrium, blood goes down to the left ventricle and is squeezed through the aorta, which distributes blood to the rest of the body. Between the pulmonary artery and the aorta is a connection called ductus arteriosus. The ductus arteriosus allows blood to move from a place of high pressure, which is the pulmonary artery, to a place of low pressure, which is the aorta. The presence of the ductus arteriosus explains why not too much blood goes into the pulmonary artery trunk and does not go to the lungs and ends up in the aorta, then to the rest of the body. Since the coronary and carotid arteries are the first branches of the ascending aorta, the heart muscles and the brain are supplied with well-oxygenated blood. A small amount of blood from the inferior vena cava is prevented from entering the left atrium and remains in the right atrium. It mixes with desaturated blood returning from the head and arms by way of superior vena cava. Desaturated blood from the superior vena cava flows by way of the right ventricle into the pulmonary trunk. During fetal life, resistance in the pulmonary vessels is high, such that most of this blood passes directly through the ductus arteriosus into the descending aorta, where it mixes with blood from the proximal aorta. After coursing through the descending aorta, blood flows toward the placenta by way of the two umbilical arteries. The oxygen saturation in the umbilical arteries is approximately 52 to 58%. During the course from placenta to organs of the fetus, blood in the umbilical vein loses its high oxygen content as it mixes with desaturated blood. Theoretically, mixing of blood occurs in 5 places. We have the liver. In the liver, this blood mixes with blood from the portal circulation. Then the inferior vena cava. The blood mixes with deoxygenated blood returning from the lower extremities, the pelvis, and the kidneys. The other place where blood mixes is the right atrium, where it mixes with desaturated blood returning from the head and arms through the superior vena cava. Then we also have the left atrium, where it mixes with desaturated blood returning from the lungs through the pulmonary vein. Then the last place where it mixes is in the entrance of the ductus arteriosus to the descending aorta, where the blood mixes with blood from the proximal aorta. Let us now discuss the conversion from fetal to infant. So, you are going to find that the left side of the heart causes the foramen ovale to close. More heavily oxygenated blood passing by the ductus arteriosus causes it to constrict. Functional closure of the foramen ovale and ductus arteriosus occurs soon after birth. Overall anatomical changes are not complete for weeks. So what happens to these special structures after birth? So there is atrophy of the umbilical arteries. The umbilical vein becomes part of the fibrous support ligament for the liver. Then there's atrophy of the foramen ovale, ductus arteriosus, and ductus venosus. And they all become fibrous ligaments. The umbilical cord is clamped, the placenta is loosed, then there is closure of the ductus venosus. Blood is transported to the liver and portal system. Loss of the placenta leads to the following. First, breath and lungs expand and fluid is expelled. There is decreased pulmonary resistance and increased pressure in the left atrium. There is closure of the foramen ovale. There is increased systemic resistance and there is decreased pressure in the right atrium. There's also a change from right to left shunting to left to right blood flow. There's also increased oxygen levels in pulmonary circulation. And then there's also closure of the ductus arteriosus. Let's now discuss the differences between fetal and infant circulation. Let's start with fetal. In fetal circulation, there is low pressure system, right to left shunting, lungs are non-functional, there is increased pulmonary resistance and decreased systemic resistance. Then in infant circulation, there is high pressure system, there is left to right blood flow, the lungs are functional, there is decreased pulmonary resistance, and there is increased systemic resistance. So they are the opposite of each other. Let's now discuss the neonatal circulation. At birth, fetal circulation must immediately adapt to extrauterine life, which is gas exchange is transferred from the placenta to the lungs. So soon after onset of spontaneous respiration, placenta is removed from circulation by clamping umbilical cord or constricting of the umbilical arteries, which increases the systemic pressure and the vascular resistance. So onset of spontaneous respiration expands the lungs, which brings oxygen to pulmonary alveoli. So this is a diagram summarizing the process that takes place when fetal circulation ends and neonate circulation starts. So first thing, when the umbilical cord is clamped and the respirations are initiated, there's going to be an increase of partial pressures of oxygen levels. This is going to result in three things. There's going to be a decrease in pulmonary vascular resistance. There's also going to be an increase of systemic vascular resistance. And lastly, there's going to be pulmonary resistance, which is less than the systemic resistance. Now, when there is a decrease of the pulmonary vascular resistance, it's going to result in an increase of pulmonary blood flow, which is going to lead to an increase of blood pressure in the left atrium and a decrease of blood pressure in the right atrium. This is going to lead to the closure of the foramen ovale. Then when there is an increase of systemic vascular resistance, it's going to lead to a decrease of systemic venous return, which is going to result into cessation of umbilical venous return and overall leading to the closure of the ductus venosus. When there is pulmonary resistance which is less than the systemic resistance, it's going to lead to left to right shunting, which is going to result into closure of the ductus arteriosus. So the heart rate slows as a result of the baroreceptor response to increase in systemic vascular resistance when the placental circulation is eliminated. Before birth, pulmonary and systemic resistances causes 90% of blood to go through the ductus arteriosus into the descending aorta. After birth, 90% of blood goes to the pulmonary arteries, with pulmonary blood flow increasing from 35 mL per kg per minute to 160 to 200 mL per kg per minute. Let's look at the changes in fetal circulation after birth. So the shunts that we have are the ductus arteriosus, the foramen ovale, and the ductus venosus. So there's going to be a functional closure of the ductus arteriosus in 10 to 96 hours after birth. Then an anatomical closure is going to occur 2 to 3 weeks after birth. Then what is going to remain is going to become the ligamentum arteriosum. Then for the foramen ovale, there is going to be functional closure within several minutes after birth. Then the anatomical closure is 1 year after birth, and then what remains becomes the fossa ovalis. With the ductus venosus, the functional closure is going to be within several minutes after birth. Then the anatomical closure is 3 to 7 days after birth. Then what remains becomes the ligamentum venosum. Okay. Then there's also a change from the umbilical arteries to umbilical ligaments. So to appreciate the process of fetal circulation, this is a diagram which is here. You can study it. Make sure that you pause the video and study the diagram. This is something that we've already discussed. Okay. We also have this diagram. It's still showing the fetal circulation. So you can also pause this one and study the diagram to appreciate the process of fetal circulation. Okay, there is also this diagram here. Also pause the video and then study the whole process. So this is everything that we've discussed now in a diagram. That's all I had for you on fetal circulation. See you in the next video session.